Well, I'm just starting. So, hello everyone. Welcome to today's session. Today we have with us Dr. Atul Kumar Taneja. He'll be talking on meniscal ramp lesions, anatomy, classification, and diagnosis. He's an assistant professor of musculoskeletal radiology at UT Southwestern Medical Center, Dallas, Texas. And he has a big experience of more than 10 years in two top Brazilian hospitals. He has published multiple articles, served as editor and reviews for the leading journals. He is an active member of ISS, ARRS, ESR, RSNA, and have lectured in multiple international meetings. He was also a part of radiology team serving the Rio 2016 Olympics. And there are various handles which you can also see on his first page. So you can just follow him back on those handles. And it is a really great pleasure to have Dr. Atul over here covering a very interesting topic which people have a lot of queries about. So I think post this talk, all the queries will be settled down. And we are really happy to have Dr. Atul here with us to talk. All over to you, Dr. Atul.
Thank you very much, Dr. Ankita. It's a great pleasure to be here. I'm always fan of the Cafe Röntgen efforts to spread radiology knowledge and so great lectures for all around the world. So it's a great honor to be here, and thank you for the invitation again. So the topic we're going to speak today is meniscal ramp lesions. This is such an interesting topic that I like a lot. Oops, I did something with my screen here. Just 1 minute. Let me try to share again. All right. So I have no conflicts of interest. And as you see, I did this search on PubMed a few months ago, and you can see the great increase in the interest on ramp lesions. This graph represents publications over the years, and you can see how much has increased over the last couple, 3-4 years. This means we all should be aware of this entity when we speak about it with our orthopedic surgeons in our reports. And what is a meniscal ramp lesion? Meniscal ramp lesions can be defined as peripheral tears affecting the posterior horn of the medial meniscus in a medial-lateral direction, leading to either meniscal capsular or meniscal tibial separation. That's the full definition. Why ramp? Ramp will be just a ramp. You can use many different analogies for that. This, like the tire here, the wheel will be the femoral condyle, and the posterior horn of the medial meniscus will be the ramp. Also, when they look from the anterior approach in the arthroscopy, they see the posterior horn of the meniscus as a ramp. So that became the name for that. What's the incidence of meniscal ramp lesions? Meniscal ramp lesions are thought to happen ranging from 15 to 42% of patients that undergo ACL reconstructions. So they can be very significant. They have very important biomechanical consequences, especially they will lead to increased anterior tibial translations in patients that already have ACL deficiency. And they will increase the instability in these patients, and it's way much more frequent than previously thought. Ramp lesions remain significantly underdiagnosed. Therefore, if not repaired, many of them will have this chronic instability related to the meniscal itself, not only to the ACL. And also, the surgeon needs to be aware of that because he needs to employ some specific arthroscopic, either a accessor portal or a different portal to approach the posterior horn, which is not easy to see on the standard arthroscopic portals. A systematic approach, both for MRI and for surgical exploration, is needed, either if it's using a standard approach or using additional portals. So which are the risk factors for ramp lesions? So there are many Risk factors versus associate findings is a very broad topic. What have been published so far is that the presence of a bone contusion in the posterior medial tibial plateau, chronic ACL injury, and varus knee are very important risk factors. Additionally, increased medial meniscal and tibial slope, increased this the angulation of the tibial slope. Oops, sorry. Also identified as a risk factor. Edema, as I said, and the patients that present edema on the tibial plateau, they have way much more chance to have a ramp lesion. But it's not mandatory to have the tibial plateau edema. Okay, I have been asked about that before. Also, male sex, age below 30, meaning young patients, posteromedial tibial edema on MRI, lateral meniscal tears concomitantly, complete ACL tears, and also in chronic settings. So meniscal ramp lesions can happen not only in the acute setting, but also they can show up later on the chronic setting. All right. So which are how can we help with that? So MRI studies have presented variable sensitivity and specificity to detect ramp lesions. The main reason for that is that they have so some orthopedic surgeons, orthopedic literature will say, oh, there is a very low sensitivity, 48%. But as we know, as radiologists, we know we are very picky, we are very detailed, and radiology studies can give you up to 70, 90% of specificity. So it has a varied range. We have published that about that before, and we show there is a very, very high correlation between radiologists and also arthroscopically proven meniscal ramp lesions. So increasing the awareness of this entity, both for the radiologist and orthopedic surgeon, will make us achieve even more better rates during our readings. 3 Tesla MRI definitely have higher sensitivity. This study showed 83% compared to 67% against 1.5 Tesla. And the most sensitive finding, according to this author, was irregularity of the posterior margin and complete fluid filling. I'll talk about this very soon. So let's remember a little bit what's the anatomy of the posterior aspect of the medial meniscus. So the posterior capsular junction of the medial meniscus is composed by the meniscocapsular ligament up here and the meniscotibial ligament down here. So let's cut this and have a better view. So we are seeing the posterior horn. Superiorly, we will attach the meniscocapsular ligament and inferiorly meniscotibial ligament. In a normal patient, you will see fat here. You won't see edema. You won't see any tears. And sometimes not that easy to differentiate these ligaments. But if you start to pay attention, if your image quality allows you, you're going to find these both ligaments normally. And then they come to this posterior margin of the medial meniscus as a common attachment. Together, they will stabilize the knee against that anterior tibial translation that happens during ACL tear, and also against the posteromedial rotation. Ramp lesions, they occur in the peripheral zone, the red zone as we call it, of the medial meniscus, where these attachments will merge. So this is our hotspot here that we need to be very careful. And as I said before, they can happen either in acute setting, acute ACL injury, you have a ACL tear, you see the meniscal ramp lesion, or in the chronic setting, they can show up later. That's very important to know because sometimes in the acute MRI, we won't be able to see, we just see edema. But after the edema has resolved, months or years later, and the ACL tear is still there, you go back and check, you see the ramp lesion. So also in chronic ACL deficient knees. And let's move to the image itself. So MRI, what should we do? We should check consecutive sagittal images, right? Check carefully the meniscocapsular junction, the posterior horn of the meniscus itself. Also, I use the axials to have an idea of the medial lateral dimensions. This is the conventional MRI. So, and we can also advance to modern techniques like 3D MRI. I'll show you some nice images now. Ultrasound is very interesting because uh, after you learn how to do it, there are specific maneuvers I'll show you also that you can try to assess the ramp lesion under ultrasound. All right. What do we need for MRI diagnosis? There are not definite criteria. I mean, we don't need to use any criteria. Oh, this fulfills two or three criteria. No, you can have a few of them. You can have not that clear criteria, but you need to increase your suspicion for a ramp lesion. So usually we will see a longitudinal vertical tear or oblique tear in the peripheral zone of the posterior horn of the medial meniscus. Okay, that's the main finding. Also, irregularities along the posterior margin of the meniscus that will lead to a focal discontinuity or step-like deformity and involving the capsular attachments. A fluid filling that gap between the capsule and the posterior horn. That's a very interesting finding. And also soft tissue edema of the capsular junction to the meniscus, the capsule itself, posterior oblique ligament itself, or a medial collateral ligament also. Edema in the posterior medial corner of the knee is very important also. Secondary findings, ACL injury. So that's very interesting discussion that for many authors, we can only call ramp lesions when there is an ACL injury. That's a definitional thing. It doesn't matter. You will see the ramp lesion. You can see the ramp lesion even without the ACL tear. But the question is, should we call ramp lesion or not? That's up to you. But we see that not that commonly, but you can see a ramp lesion without ACL tear. It's not that common, but can happen. And also bone bruise of the posterior tibial plateau, as I mentioned, very useful finding during MRI. That means you need to be careful about the posterior medial corner of the knee. And how about classifications? So few classifications have tried to address the ramp lesions. It started with Seal in 2017 and Tonon in 2016. So Tonon classification, I think it brought the attention to the literature about the ramp lesion. This was back in 2016-17, where he brought the idea about the tear pattern itself, the direction, thickness, partial or full injury, meniscocapsular junction, anatomy, red zone, meniscotibial ligament disruption, and stability. And then a few years later, 2020, in scalp radiology, Griff have extended that classification. That's what I'm going to show you. And we have a little bit more detail when it comes to anatomy. All right, type 1. Type 1 of the meniscal ramp lesions will be the meniscocapsular injury, the meniscocapsular tear. But actually is the tear of the meniscocapsular ligament, the one that's in the superior part of the posterior horn. All right, let's an example. You have the ligament coming and it should be attaching to the meniscus and you have a disruption there. This sagittal T2 show you, and we can correlate with the axial. How long is that edema affecting? You see, it's very subtle. In this image, I can tell you there is a tear there. But let's say you do not have that definition, or it's not that clear to you. What would I do? I would definitely write in my report that I see edema of the meniscocapsular junction. Okay, or you can even use the term sprain of the meniscocapsular junction. That will increase the suspicion for something going on or affecting the posterior horn. But maybe if I don't see that beautiful tear, I might not call it like a ramp lesion, but I'll put also in my impression there is edema, there is a sprain of the meniscocapsular junction. That's very important. And more than 10 years ago, we did not speak about ramp lesions, but the meniscocapsular disruption, that the term we used before, that's actually what the ramp lesion is a meniscocapsular disruption, which means the meniscus has detached from the capsule at some point, and it's not a meniscal substance tear in many cases. It's a meniscocapsular tear. So it means different, it needs a specific approach during surgery to repair that. Okay, so type 1, meniscocapsular ligament tear, or just meniscocapsular edema, or meniscal capsular sprain, you name it. Type 2, we have a partial superior tear. Okay, so in type 2, it's going to affect the meniscus itself, the meniscal substance, and Griff have expanded this definition to partial superior peripheral posterior meniscal horn tear. All right, so here we see consecutive images on sagittal. We see a partial tear involving the superior part of the peripheral zone of the meniscus. All right, and you can see that the meniscal capsular ligament is also torn here, but is also affecting the superior part of the meniscal substance. Type 3A. So 3A will be a partial inferior tear, and Griff has expanded to partial inferior peripheral tear of the posterior horn of medial meniscus. All right. So 3A. So we have a tear of the meniscal substance involving the inferior articular surface. We can see that on the sagittal in this image. As I go more medial, I can see beautifully the meniscotibial ligament here normally attaching. So this is a 3A. How about 3B? 3B, the tear will be involving also the meniscotibial ligament. Okay, so that will still be a partial inferior tear, but in this case involving the meniscotibial ligament tear. We have a tear in this case of the posterior horn involving the inferior articular surface, and then the meniscotibial ligament is gone. It's gone, and we see also that bone edema I was talking to you about. And then you can see on axial the extension of the tear involving the posterior horn and the extensive edema of the capsule. So we have a tear of the meniscal substance and injury of the meniscotibial ligament. I'm so happy here. I see more than 300 people have joined the lecture. I hope you all learned something. I hope to help you in understanding ramp lesions. All right, type 4, Griff 4A, complete tear. This will be the prototype of the ramp lesion. This is the type of the lesion. Okay, we know about this. Oh, is this now a ramp lesion? Yeah, it now has this beautiful name. So it's a complete tear of the posterior horn. The posterior horn, the peripheral zone, has a complete tear from the femoral to the tibial articular surface, and it's involving the meniscal substance itself. You can see here, you can see on axial how long it extends. See, it's extending the entire posterior horn and the transition to the body, and you see a bone bruise of the posterior edge of the medial tibial plateau. How about 4B? It's very similar, but it's not involving the meniscal substance itself, but it's involving that common attachment I showed you a few slides before. This will be the complete meniscal capsular junction tear or meniscal capsular disruption, as we used many years ago. So the tear will be at this attachment. All right, so we have a gap. You guys can see this. There is a gap. The meniscus is far from the capsule. We have fluid and edema. On axial, you can see this extension to the, how long it extends. Just remember that sometimes you're going to see some fluid there in this posterior horn of the medial meniscus, but there is no acute injury. There is no ACL tear. There's nothing. Sometimes you can see some fluid there because also there's a recess, the posterior recess of the knee extending to the meniscus. So what I'm trying to say is that you need to look the whole picture there. Is there edema of the pericapsular fat pad? Is there edema of the meniscal capsular junction? Is there a real gap? Is there an ACL tear? All right. So just don't get confused when there is some fluid, and usually the fluid goes a little bit posterior. You're gonna see the fluid going posterior, but you won't see like a gap. All right. Type 5 is very rare. Type 5 will be a double tear. Peripheral posterior horn, medial meniscus, double tear. So in this case, a postoperative case, there is a re-tear of the ACL, a tear of the graft, and you can see a tear involving the substance and another tear involving the meniscal capsular junction. I recently shared on my social media accounts, Telegram also, a case that I asked everyone, which is this, how would you classify? The right answer is type 5. I'll show you later. I'll send later the other images. There was a double tear, and it was interesting because we could only see that on the 3D. All right, so this is a summary of what we just talked about. Type 1 meniscocapsular ligament tear, type 2 partial superior tear, type 3 partial inferior, 3A does not involve the meniscotibial ligament, 3B involving the meniscotibial ligament, type 4 complete tear, 4A involving the meniscal substance, 4B involving the meniscal capsular junction. Type 4, in my experience, is the one that's easier to see and maybe one of the most commons that I see. And type 5, very rare double tear. All right, so how about 3D? I told you we can do some advanced imaging. We have this protocol in our institution. All joints have a 3D sequence, especially when it's an orthopedic request, orthopedic protocol. We acquire in 0.8, 0.7 millimeters. It's very thin and it's isotropic. We can reformat in any plane without loss. Let me show you this case. So 18 years old male with pain after twisting the knee 2 months ago. He was dancing at a wedding. He was doing some Bollywood moves and somebody pushed into him. So then he twisted the knee. So this is the full 3D sequence. You can see it's fat suppressed. It's acquired either in spare space of FSPGR. We pass through the lateral meniscus and now you can briefly see the ACL tear and the medial meniscus type 4 injury. Let me give you some still images here. So type 4 injury of the posterior horn, and you can see the extension beautifully on this axial reformat. Another case, the same case, patient went to OR and they did some meniscal debridement to stimulate healing. They did 5 vertical sutures passing through the posterior horn, and they reapproximated the meniscus to the capsule to create a stable inside-out repair. So they used the inframedial portal. Next case 2, also 18 years old. He was playing soccer, and when he went to make a cut, planted, and pivoted. Well, when he felt that classic knee shift in the pop of ACL injury, and we can see the 3D image in this case, a lot of bone bruise. We beautifully see the type 4 lesion, in this case involving the meniscal capsular junction. This patient also had a lot of joint effusion, full thickness ACL tear, bone bruise on the lateral compartment as well, tear of the lateral meniscus there, and full picture of the ACL injury. So we can see the meniscal capsular injury here, and also on axial, the extension of the injury. This patient they used the anteromedial, anterolateral portals. They did ACL repair. The medial meniscus and lateral meniscus were debrided, rasped, and repaired. We're using this technique, which is called fast fix sutures, which is a minimally invasive all-inside technique for medial meniscus and lateral meniscus, and they use it the transnotch approach. Another the 3D case, 23 years old female, left knee dislocation during an accident. So you have an extensive tear of the ACL, PCL, medial collateral ligament, detachment of the semimembranous tendon, posterior medial injury, posterior medial corner of the knee injury, and you have a extensive edema of the meniscal capsular ligament. And then we see here something going inferiorly, and you see the detachment of the meniscotibial ligament. Beautiful case number 3, number 3 and type 3. So this will be a partial inferior tear, 3B involving the meniscotibial ligament. All right, differentials for ramp lesions. We are talking about differentials that affect the posterior aspect of the menisci, either medial or lateral. We should remember that the lateral also has some interesting type of lesions, such as the zip lesion, the so-called zipper or Risberg rib, which which happens when there is a detachment of the Risberg ligament, the posterior meniscotibial ligament, from the posterior horn of lateral meniscus. The Risberg ligament will have extensive attachment to the posterior margin of the lateral meniscus. When there is this zip lesion, it opens up. It's called a Risberg rib. There are some tentative measurements for that. Some would say 11 millimeters, some would say 14. There is no clear cutoff. Just look at the whole picture, what you see in the meniscus, what you see in the bone, what you see in the ACL. In this case, we briefly see this extensive bone bruise. You can see the tear of the posterior horn, the meniscal substance, and also the Risberg rib. Flipped meniscus sign, very classic, double delta sign. What do we see in the flipped meniscus? It is also a meniscal capsule disruption. But what happens is that the posterior horn gets flipped and displaced anteriorly next to the anterior horn. So in this case, I describe and call it the flipped meniscus. I won't use the term ramp lesion in this. And especially in this case, it's affecting the lateral meniscus. It can happen the medial, but it's very, very rare. Most of the cases I've seen it happened to the lateral meniscus. And meniscal root tears, they have gained way much more importance every year. They are gaining a lot of attention. Remember to look carefully for the meniscal roots. Use the coronal. Get nice images on coronal. That's where you can beautifully see them on your cross-sectional view when we're talking about the posterior horn. And ghost sign, it's used for the radial tear, meniscal radial tear. You're using the consecutive 2D sequence, the sagittal sequence, and all of a sudden the meniscus is gone. Ghost sign, that will also help you for the posterior root of the medial meniscus. Okay, in this we see also an axial nicely. Then there are Laprade classifications for root lesions. They are used for in many institutions, especially orthopedic surgeons like that. All right, how about ultrasound? I told you a lot of MRI, which will be the for us radiologists the gold standard, and we are showing there is a high correlation with surgery. Still, surgery will be the gold standard, and MRI is getting very close to that. And how about ultrasound? The advantage of ultrasound, as you know, it can perform in any position, real-time imaging. So this interesting paper from a Japanese group, they published it in Arthroscopic Techniques in 2021. They show how to do it. I'll just play in a second. Semimembranous muscle, use it as a landmark. You set the probe above the semimembranous myotendinous junction. The patient is positioned in prone with the semi-flexed knee about 70 degrees. And the most important part is to have someone to help you to hold the patient's foot, and then you ask the patient to do some contractions, trying to flex the knee. That's that's the trick to get the image of the ramp lesion ultrasound. There's still no studies on accuracy. So this is the let me play from here, if you can see. Oops, sorry, clicking here. So now when now during the contraction is when you're gonna see the ramp lesion, the gap between the capsule and the posterior horn. Okay, let me show you some other case under ultrasound. So that's some nice illustration by my friend Gonzalo from Chile using ultrasound. I just played so you can see. So uh, that's what we expect, a peripheral tear of the medial meniscus, the same positioning along with the semimembranous, semiflexed knee, and then you ask the patient to do some contractions, and then it will open up this gap. So you can do it on ultrasound. It needs, of course, some training and doing a lot of cases until you get to that. Let's say you have a patient on the MRI and you can bring to the ultrasound suite to try. It will be interesting training. You can beautifully see the gap during flexion. It's another case. And okay, that's the correlation of the ultrasound image. You can see the gap during the flexion movement. That's the meniscal capsule disruption, and that's the correlation of the same patient MRI, type 4, in the same position. Right, moving to the final parts of our talk, treatment. The optimal treatment for ramp lesions, they are there. There's a lot of debate still. There is a lack of clear algorithm, but speaking to the orthopedic surgeon from many different institutions, they use similar approach to decide if they're gonna fix it or not. So they consider stable between 1 to 2 centimeters. If below that, one class 1 to 3, and if there is, especially if there is no displacement of the posterior horn under probe pressure, under probe during probing, during arthroscopic surgery. On the other hand, on the opposite, if they are considered unstable if larger lesions, class 4 and 5, and displacement under probing. Treatment can range from biological treatment like debridement, rasping, curettage, trephination, uh, which is preferred for stable lesions. And unstable lesions, on the other hand, require repair. This can be done using an all-side technique through the anterior approach or additional posterior medial approach or inside-out technique. They have been shown great outcomes from this, from suturing, from repairing these lesions. Still, no great prospective trials. On the surgical technique side, there are different techniques like suture hook. I'll show you some images. All inside technique, inside out, anchor based repair. This is a very surgical thing. They vary according to the cost. If there is a need of an additional portal or not, or if they can do using the same transnaut approach from a intermedial interlateral portal, and if there is injury to the meniscus itself. So new techniques have been shown. So this an interesting illustration by Arthrex show you how to repair that, how they do repair that. All right, beautiful illustrations. Again, so speaking to the experts, I spoke to great knee surgeons, internationally renowned surgeons. So they said stability. I verify stability during the surgery. If there is meniscal displacement, if there is more than 15 millimeters. So remember, I showed you 1 and 2. These are literature measurements. So this is right in the half of the way there. So surgery usually recommended if unstable, if there is an ACL re-tear higher tibial slope, meaning higher angulation of the posterior margin of the medial tibial plateau. If there is hypermobility or hyperextension attitude of the knee, and they prefer to use additional posterior medial portal. So different techniques. This is the all inside suture hook, can be done using the transnotch approach or with additional posterior medial portal as they prefer. Most of the surgeons prefer all inside technique. Another example, was meniscal ramp lesion tear type 4. We can briefly see the gap between the capsule and the meniscus, and the suture was done with all inside approach, all inside technique through a posterior medial approach. We're seeing this from posterior. So um, since MRI demonstrate great moderate to high sensitivity and specificity for ramp lesions, routine arthroscopic assessment is recommended if there is a suspicion. They need to look themselves, not only we need to increase the awareness, the suspicion for that, and let the orthopedic surgeon know. Failure to repair is associated with increased rotational laxity, tibial translation, persistent pivot shift, and poor outcomes, meaning re-tear of the ACL. Postoperative aspect, this is acute ramp lesion type 4, and then a few months after repair, after surgery, we can see the gap. The gap was it's not there anymore. We can see how far the meniscal substance was displaced, and you see the suturing, but still you don't see any fluid filling the meniscal substance. Remember, postoperative aspect of menisci, tendons, ligaments, they won't look like normal anatomy. But one thing you need to be sure, if there's not a re-tear. In this case, we can briefly see there is repair tissue, this gray tissue irregularity, which is expected to the postoperative aspect, but definitely there is no more tear here. For those who are interested, two papers I'll recommend. In this paper, we did a radiology perspective on how much can we agree on meniscal ramp lesions in arthroscopically proven cases. It's published in the Knee Journal. And this another one, meniscal ramp lesions, where many of the illustrations I showed you are freely available in this paper from Insights into Imaging. And so far we have more than 50,000 downloads. Feel free just to type it on Google, you'll find it. And I think that was probably my last slide. And thank you very much again, Dr. Ankita, for the kind invitation. I'm happy to take any questions.
Yeah, thank you. Thank you so much for taking us so deep into the meniscal ramp lesions. Lovely images as well. So, and also the video illustrations, I think, helped us a lot. So there are few questions. So first of the question is in Q&A, which says, is ACL tear a must to say ramp?
I'm sorry, can you repeat that?
So the first question says, is ACL tear a must to say something as ramp? So I think they're trying to...
Yeah, that's one thing I mentioned. I mean, so there are two different things. One is we can see ramp lesions even without ACL tear. That's not the common scenario, but they do happen. That's one thing. Another thing is that the most common use of the term ramp lesion is we use that term in the setting of the ACL tear.
Right. Then the next question, we have a few questions in chat box as well. I'll just read them out. The first question is, sure. Does the anterior translation of the medial meniscus on ultrasound occurs in all types of ramp lesions?
No. You will see on ultrasound easily on type 4. Okay. I will not say about the other types, because on the other types there is no much displacement, no much gap. So usually on type 4, which is the one that there is an anterior displacement of the meniscus. And still, ultrasound have very few studies on that. Very few studies on ramp lesions under ultrasound. We might see in the near future, but I'll leave that beautiful image I showed you for the type 4.
Okay. So do you do ultrasound regularly to look for ramp lesions?
No, no, we are very MRI based practice, so I don't we don't do that many cases under ultrasound.
Okay. Then the next question is, can you tell us about the 3D sequence?
Yeah, sure. So 3D sequence we use in all joints, shoulder, elbow, knee, all the great bigger joints. We use a 3D. We have a 3D in all our protocols. When it's orthopedic protocol, meaning joint derangement. So we do the 3D. 0.7, 0.8 millimeters of slice, isotropic acquisition. It's usually, I'm seeing the question here is asking which is the sequence. So we usually do either a spare fat suppressed, space fat suppressed, or FSPGR, depending on the scanner.
Yeah. Yeah. So then the next question is, what is the counterpart of ramp lesion for the lateral meniscus?
Yeah, then
Is
would
there
be
something
the
like
yeah. No,
no?
for the lateral meniscus, I would say the one that gets closer to the ramp is the Risberg rib. Because the lateral, I mean, the posterior anatomy of the medial meniscus is different from the lateral. In the medial meniscus, the meniscus itself, it's attached to the capsule, like we showed. On the lateral meniscus, the meniscus is attached to the ligament, to the Risberg ligament. So the Risberg rib will be the counterpart of it.
Yeah. Uh, then what is the interval for routine post-operative images? Post-operative imaging.
So I would say if there is a need to assess the post-operative aspect, at least 3 months from surgery. Before that, you're going to see too much inflammatory changes and edema. So I would say definitely after 3 months, if needed. If there is no complaint, if there is no symptoms, no need at all.
Yeah. And how long? So like 3 months. Also, you can see sometimes stages. So do you wait even more